Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The speakers and planning committee members have disclosed no conflicts of interest. To receive contact hours for this educational activity, participants are required to attend the webinar and complete the evaluation form, which will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. On behalf of Sigma, we would like to thank our speakers for sharing their expertise with us today. Today, our webinar speakers from the International Society of Professional Identity in Nursing will be nurse attorney Joanne Clausen, Dr. Rhoda Owens, and Dr. Kristen Pretty. Ms. Clausen is a nurse and an attorney. Her nursing history includes the practice of medical surgical nursing, gerontology, and mental health nursing in a variety of settings. She has practiced law in the areas of medical malpractice, personal injury, products liability, nursing home abuse, and disciplinary defense. She has been a clinical associate professor at the University of Missouri, Kansas City, and served 2 terms on the Kansas State Board of Nursing. Dr. Rhoda Owens is an assistant professor at the University of North Dakota College of Nursing and Professional Disciplines. Dr. Owens is a member of the International Society for Professional Identity in Nursing's Dissemination Work Group and co-chairs the Propelling the Science Work Group. In addition, her current and published research involves the topics of professional identity in nursing formation, nursing workforce intent to stay, recruitment and retention, and nursing education. Dr. Pretty has been a nurse for 30 years with a clinical background in labor and delivery nursing. She has taught undergraduate nursing students for 23 years. Dr. Pretty has conducted grounded theory research on formation of professional identity and serves on the advisory council of the International Society of Professional Identity in Nursing. Her mission is to understand, touch, and improve nursing education in the United States and around the world. Thank you all for sharing your time and your expertise with us today.
On behalf of the other presenters and myself, we want to thank you for taking time out of your very busy schedules to attend the presentation or this webinar. So the learning objectives for this webinar are as follows. First, to discuss the definition of professional identity in nursing. Second, describe challenges and barriers to professional identity formation. And lastly, identify nurse educator practices that will foster professional identity in nursing. Next slide, please. So this is the 3rd webinar of a series of 5 webinars that are being co-provided by Sigma and the International Society for Professional Identity in Nursing. Efforts to meet our goals will support the mission and vision of the International Society for Professional Identity in Nursing. Our mission is to illuminate and foster professional identity in nursing around the world. Our vision is that every nurse in the world will fully embody their professional identity to maximize the well-being of the people they serve. Next slide, please. It is important to briefly review the definition for professional identity in nursing and the 4 established domains. Building on some really exquisite work on professional identity in medicine, Dr. Nelda Godfrey and colleagues proposed a definition that was then adapted and adopted by think tank participants. Professional identity in nursing is defined as a sense of oneself and in relationship with others that is influenced by characteristics, norms, and values of the nursing discipline, resulting in an individual thinking, acting, and feeling like a nurse. Next slide, please. In this slide, you will see the 4 domains of professional identity in nursing. They have been defined. First, values and ethics. Second, knowledge. Third, leadership. And fourth, professional comportment. Next slide, please. Definitions for each of the 4 domains have been developed. Values and ethics are defined as a set of core values and principles that guide conduct. Knowledge is defined as analysis and application of information derived from experiences, critical reflection, and scientific evidence. Leadership is inspiring self and others to transform a shared vision into reality. And lastly, professional comportment is a nurse's professional behavior demonstrated through presence, words, and actions. Next, I will turn over the presentation to Joe Clausen. Next slide, please.
Good evening. We begin our targeted information tonight by talking about some of the challenges and barriers to professional identity. As has been stated in prior sessions, 2 fundamental convergent things must occur. 1, the individual must develop psychologically, and 2, there must be collective acculturation into the profession. Let's take a look at some of the challenges. Next slide, please. Why don't student nurses develop psychologically? Those with psychosocial factors often comprise that vulnerable student population with which educators are well acquainted. Kristen has done some excellent work in this area and will discuss some of these issues further. Those of us who are educators are also well aware of academic stress and competing commitments that students may have. But I'd like to spend just a couple of seconds on the last 2 on this slide. The societal trend towards egoism. That is, a focus on internal personal development versus external interpersonal skills and values development. Bedzo's done quite a bit of work in this area, and he concluded that if we want to inculcate a culture of professionalism, we have to do several things. 1, we must provide opportunities for development of students and new nurses. 2, we need to provide a shift in the frame of reference from internal to external. And thirdly, we must not assume that students will just develop automatically into an externally focused nurse. Instead, we need to be explicit in onboarding them in how to take their individualism and be translated into a shared vision that serves their patients well. Lastly, we haven't done a lot of thinking about students' motivations for entering the profession. There's research out there to tell us that students who have intrinsic motivation, that is, they want to serve or help others, are much more likely to be successful as nurses than those who have extrinsic motivation. Next slide, please. So why do we even care about this? We care because what we know is that an individual who fails to develop psychologically does not develop a healthy professional identity. And what happens is there's a superficial commitment to the profession, which results in poor quality care, moral distress and values dissonance, which leads to increased stress and burnout. I can assure you from my experience on the Board of Nursing that we see this play out in different ways, such as patient abandonment or abuse, or conflict and horizontal violence between nurses. Next slide, please. Nurses who don't develop a healthy professional identity have decreased self-confidence and poor decision-making skills. Either they make decisions they shouldn't make, such as I adjusted the medication without telling anyone, or they don't make decisions they should make, like I forgot to chart because I was so overwhelmed. Most of us are very familiar with the fact that substance use disorders are very prevalent in our nursing population, and that almost 80% of all disciplinary cases in nurses are related to substance use disorders. Those in turn are connected to various forms of mental illness, particularly anxiety or depression. both of which, by the way, have escalated during the pandemic among our nurses. Lastly, an unhealthy professional identity will result in either a disproportionate self-focus or a disproportionate other focus, producing a very unprofessional comportment. Next slide, please. That leads us to the next piece of this, which is collective acculturation and professional identity. Next slide, please. There are three big influencers for collective acculturation: academia, in which all three of the presenters tonight have spent considerable time, the nursing profession itself, and then finally regulation and oversight. Next slide, please. Academia has a significant responsibility in the development of collective acculturation as it pertains to professional identity, and there are considerable barriers as well. I've already touched on the fact that we don't always think about what is our students' motivation for entering nursing. We don't do a fantastic job of early identification of at-risk students or appropriate intervention with them. Until Dr. Godfrey began her work on designing the model for professional identity, we've had a lack of faculty shared understanding of what professional identity really is. And as a result, we've had little to no cohesive pedagogical content on professional identity, pieces here and there, but cohesion has been missing. Some schools have focused more on role development. What do nurses do, rather than professional identity? Who should we be? Next slide, please. Students often have a diffuse ethical and moral clarity as it pertains to professional identity. By that, I mean that they place value on certain aspects of professional identity, such as knowledge acquisition and leadership, and devalue some others. In a study we did several years ago, we found that in a simulation lab that's clinically oriented, if we focused on aspects of professional identity, we found that we could increase student valuing of ethics, morals, and professional comportment. So we need to do more of that. Faculty focus is sometimes fuzzy because of the theory-practice disconnect that often exists between the university and the clinical setting. Furthermore, students have indicated that faculty aren't always great at role modeling. Sometimes we say, do as we say, not do as we do. Conversely, there's sometimes an inadequate preparation of nurse preceptors, particularly in the area of morals, ethics, and professional comportment. Preceptors are great at divulging knowledge and skills, but the rest of it may be left to the university faculty to deal with. So additional preparation may need to take place. And finally, in academia, we don't always handle properly students who do not demonstrate achievement of the core areas of professional identity. Either we're very late to the game in designing appropriate development strategies, we fail to fail students who will not be good nurses and shouldn't be nurses, or we lack administrative support to put into place effective policies. Next slide, please. That brings me to the nursing profession. There are impediments there as well in acculturating new nurses and students to the profession. We're a huge profession. We have so many different levels of nursing and so many different credentialing areas. It's difficult to even keep track. And what we're finding is that as we have increasing specialization, we also have nurses identifying more particularly with the specialty than with the profession at large. This certainly was part of my experience as a graduate educator. And Rhoda's talking more about identification, professional identity with nurse practitioners in her research. There are changing boundaries with the compact and telehealth that may change how nurses view themselves, but we don't have much research in this area. And there's very diffuse decision-making for the profession. I'll talk about that later on in the presentation. Next slide, please. The nursing profession itself lacks research and understanding about holistic professional identity. And that is why Dr. Godfrey made a very deliberate decision to bring in practice experts in the design of the professional identity model. There are many cultural differences depending on where nurses come from. Rhoda's going to talk more about rural perspectives, which may be different than urban perspectives. I found that to be true at the undergrad level. And then there are international nurses, either moving into a new culture to learn or within their own culture that have different perspectives than we do. Finally, there's a lack of focus on image and leadership development. Godsey found that even in 2020, the public sees the nursing profession as a subset of the healthcare system, and they don't see nurses as having autonomy or influence. So as you can see, the nursing profession itself, responsible for collective acculturation, has many barriers and challenges to professional identity development. Now I'll turn it over to Kristen and Rhoda, who will present their excellent research on professional identity development in undergraduate students and rural nurse practitioners. Next slide, please.
Thank you, Joe. It's a privilege to have the opportunity to present my research to the Sigma audience. Next slide, please. I was inspired to begin my doctoral work and investigate the process of formation of professional identity when I read the landmark US study, Educating Nurses, A Call for Radical Transformation, that was conducted by the Carnegie Foundation for the Advancement of the Professions and authored by Patricia Benner, Molly Sutphin, Victoria Leonard, and Lisa Day. This study called for 4 essential shifts in preparing nurses for the nursing profession, including a shift from a focus on role socialization to a focus on identity formation. As an educator teaching in a baccalaureate nursing program, I was most interested in what I could do as a teacher to bring about this formation. Next slide, please. My aim was to create a model that would guide educator practice. My research focused on 2 basic questions. First, from the perspective of nursing educators, what is the process that nursing students go through as they develop their new identities as professional nurses? And second, what can nursing educators do to stimulate and support this process? Next slide, please. Is that better? Can you hear better? Sorry about that. I conducted a qualitative study using grounded theory methodology. In grounded theory, the investigator seeks to uncover and construct a theory that is grounded in the real world by analyzing and constantly comparing new data to previously collected data. I interviewed 12 faculty members who were teaching in pre-licensure baccalaureate nursing programs in 4 different campus-based face-to-face nursing programs. To address the diversity in student populations, I sought out participants from 1 large state university, 2 small faith-based regional liberal arts universities, and 1 historically Black university in the southern part of the United States. I wanted to interview faculty with enough experience to address these questions of identity formation, so I sought out participants who had at least 3 years of teaching experience. My participants were all female, they were predominantly white, they ranged in age from 30 to 66, and they had up to 30 years of teaching experience. Next slide, please. The resulting grounded theory is based on the core category that emerged from my data. It's putting the pieces together, and it consists of 3 parts: entering student identities, progression towards thinking, acting, and feeling like a professional nurse, and then those educator practices that support formation of professional identity. Next slide, please. The first part of the theory describes student identities when they enter nursing school. Students don't enter nursing school as blank slates. They bring with them a diverse mix of personal, occupational, and social experience, as well as varying states of physical, mental, emotional, and spiritual health, as Joe alluded to, and varied resources to support them in their nursing education. My research participants described 4 kinds of students. The first were emerging adults, what are often called traditional students. Now, I chose this term emerging adults very specifically. It's a developmental stage that was proposed by the American psychologist Jeffrey Arnett about 20 years ago. Emerging adults are still forming their own personal identities. They're ready to explore things like love and work and their worldview. They're looking for meaningful, fulfilling work that is a good fit for their individual identities. The characteristics of this stage of life make it a fertile time for formation of professional identity. Although they have limited life experience and limited experience with the healthcare system, they also have few responsibilities competing with their education. My research participants generally felt like these students were at an advantage when it came to forming their identities. The second group is adult students. And there's been a lot of research and writing about the topic of adult learning theory. For example, a characteristic of adult learners is that they often have competing responsibilities like jobs and family responsibilities. But they have some advantages too. They bring their life experiences to their education. And when it comes to nursing education, they often already have a mental framework for healthcare and how the healthcare system works. Their task is to integrate a nursing identity into their identity that already exists. Now, my research participants described a subcategory of adult students, those students who are transitioning from another healthcare occupation into nursing, such as licensed practical or vocational nurses, or first responders, or nursing assistants. Formation of identity as a registered nurse presented particular challenges in this group because it required them to relinquish an existing identity and to change their existing mental framework about viewing patient care situations. These students also perceived themselves as different from the rest of the students, and they tended to have unrealistic expectations of their classmates who didn't have their experience in the healthcare system. It takes these students some time to understand that the role of the registered nurse isn't the same as their current role, and it requires expanding their thinking. For example, licensed practical nurses had a tough time taking on the autonomy of a registered nurse. Now, I personally believe that we need to handle this group very carefully. We need to show a lot of respect for them and understand that what we're asking them to do is let go of their existing identity, and that was already a hard-won identity. The final group of students, which I call vulnerable students, was described by my research participants. These were students who experienced significant social, economic, and psychological barriers to forming a professional nursing identity. Many of these students came from historically disadvantaged groups, including first-generation college students, minority students, and students with socioeconomic challenges. Some of them came from backgrounds of abuse and violence. These students needed to develop a secure and empowered personal identity to support the development of a professional nursing identity. As you can see from this diagram, these students can be found in any of the other categories. Vulnerable students needed additional support in terms of finding mentors that share their backgrounds and resources to support psychological health and academic skills. They sometimes also need additional time to develop their professional identity. So some of them would go to school part-time and stay in nursing school a little bit longer. Now, I spent many years teaching in a university that had a very diverse student body. So the ratio of students you see in this diagram looks very much like where I taught for a long time. But next slide, please. A lot of you may teach in a less diverse environment where the population's more homogenous. So like in the picture on the left here, where most of the students are the traditional or emerging adult students. And that poses its own challenges. For example, most of the resources on your campus may be set up to meet the needs of 18 to 22-year-olds, and the students in these other categories may feel really marginalized. Whereas in my diverse university, there were a lot of resources for students in all of these groups. Next slide, please. The second part of the framework, putting the pieces together, describes the progression of baccalaureate nursing students as they develop a professional identity. Now, I framed the descriptions based on our definition of professional identity in nursing, a sense of oneself that's influenced by characteristics, norms, and values of the nursing discipline, resulting in an individual thinking, acting, and feeling like a nurse. As you can see, this emerging map of developmental milestones focuses on the final 4 semesters of education when students in typical U.S. baccalaureate programs attend their clinical experiences. From the perspective of the nursing educators in this study, the most profound changes occur in the way students think. Participants use the phrase putting the pieces together to describe the basic process of learning how to think like a nurse. Students start out thinking piece by piece, and then over the course of their education, they make more and more connections in their thinking, ultimately developing the ability to see the big picture of patient care. Students move from thinking that nursing is caring in a pretty simplistic fashion. I mean, everybody knows that nurses are caring, right? And that nursing is doing tasks. Like my pre-nursing students would often describe nursing as nurses give shots and do what the doctor says to do. But they move from that simplistic view to understanding that nursing is really complex, context-driven thinking. And over the course of this experience, they expand their worldviews. They develop more nuanced ethical thinking, moving from black and white, this is definitely right or wrong, to being more comfortable with ethically ambiguous situations and being willing to do a little more exploration about what might be the right thing to do in a very specific situation. Now, moving on to feeling like a nurse, the biggest change that happened in the way students feel like a nurse had to do with their confidence. Students start out feeling overwhelmed and fearful of patient interactions. In fact, one of my participants told a very funny story that she took a student into a patient room, introduced the student to the patient, said, "The student's going to stay here and visit with you a little bit." She walked out of the room and she said, "I felt this presence behind me," because the student had followed her out of the room. So she had to take the student by the hand and back into the room because the student was so nervous about interacting with the patient for the first time. But gradually, students develop confidence and comfort in their role as nursing students, and they begin identifying themselves as nurses by the time they graduate. However, when they get close to graduation, it's really normal for them to get completely terrified again because they're about to graduate and go into the real world of employment. Now, students grow in acting like a nurse by moving from being dependent on their faculty to actively seeking out learning opportunities and only using their faculty and preceptors as resources when they need to. That behavior is called delegating up. And it's a characteristic of the advanced beginner phase of Pat Benner's novice to expert framework, or sort of the second level of moving from being a novice to being an expert. Acting like a nurse also encompasses behaviors related to professional accountability. Students at the beginning of their programs may be surprised that there really are rules that have real consequences. But by the end of their programs, they hold themselves and they're held accountable to levels of accountability that look like a professional nurse would carry themselves to, what would be expected by their licensing boards. Next slide, please. Now, my real curiosity in conducting this study was to understand how I, as the nursing instructor, could help bring about this formation. And so this third image depicts the practices of the nursing educator, and I hope that you find this useful. The model can be used to guide your educator practices. Now, across the bottom, you'll see the administrative support, because to be effective, these practices really require the understanding and support of academic leaders and administrators. And then across the top, you see the diagrams I just showed you, the diagram of entering students' identities. And then these students move through a cycle of thinking and acting and feeling more and more like professional nurses as they go along. And that leads to those phases of development that I just described. So underneath all of this, you see the nursing educator. And I hope we have some nursing educators in our audience, because your job is to support the process by creating a safe and caring educational environment, and then implementing educational strategies that are designed to stimulate formation of identity. So as you look at this slide, this picture, it's deliberately looks like we're creating the environment in the room around the student, and we have to start from the bottom and build up. And the first thing that we have to do is understand the student. In fact, when I asked what advice my participants would give a new faculty member about teaching for formation of identity, again and again, they referred to the need to know and understand both the student population at their school and the individual students. Understanding the student is the foundation of being able to teach for formation of professional identity. And this means understanding where they begin in terms of their existing identity and being sensitive to their developmental state as they move through each semester of their nursing program. When So for example, first semester students need to be taken care of with much greater care. So when educators understand the student, they can work on this next level, creating a safe learning environment. This is important because formation of a new identity is really risky business. It's a risky endeavor. It requires a period of psychological and social instability and a full commitment to identity. And that kind of full commitment means we've got to be willing to take interpersonal risks to meet the needs of patients. My faculty participants described how they created this safe environment in a number of ways, but all depend on building a relationship of trust with the students and between the students. So once they understand the student, nursing educators can use this understanding to provide developmentally appropriate support. For example, first semester students who are overwhelmed and fearful need a lot of emotional support and encouragement. They need clear direction as they enter the clinical environment, and they need assistance in making connections between what they've learned in the classroom and how they will think and act with their patients. On the other hand, senior students are offered less direction, fewer answers, and more questions, and they need less emotional support. Next slide, please. Only after using what they know about the student to create a safe and caring learning environment can nursing educators start implementing the pedagogies that support formation of nursing identity. And my participants described several pedagogies that they would use. The simplest and most straightforward is communicating expectations. Faculty participants explicitly identified behaviors that were expected of students in the clinical and the classroom and the lab setting. Some of these were very objective and measurable, like complying with the uniform code or being on time to class and clinical. Others were more subjective, like expectations for mutually respectful communication or the expected boundaries between faculty and student. Now, there's no doubt from the data in this study and other studies that experiential learning is the most influential pedagogy for forming a professional identity. Of course, a lot of that happens in the clinical setting, but we also spend a lot of time in the lab and classroom with students. And so this experiential learning can be extended into the classroom setting, for example, through the use of narratives, through telling stories. Telling stories provides vicarious experiences for students. So nursing educators tell stories from their own experiences, or they use movie clips or videos from the internet or other forms of media. Or they'll ask students to tell their own stories or ask students to share stories of experiences they had in clinical. Another important narrative is the educator's own story of meeting the challenges of nursing school. Now, this is particularly important with those vulnerable students because they need mentorship from nurses who share their backgrounds. And sometimes the closest nurse that they can talk to is their nursing instructor. Being an effective member of the healthcare team is an important component of professional nursing identity, and educators regularly use teamwork in the classroom as an experiential learning strategy to help students develop as effective team members. Participants in this study talked about modeling more than they talked about any other strategy. But interestingly, none of them talked about modeling technical skills at the bedside. Instead, they described modeling communication, caring, and respect at the bedside. They also modeled clinical judgment by thinking out loud or by going over how they went about making a clinical decision. They also modeled a number of important aspects of working with the healthcare team, including how professionals communicate with each other or how professionals confront and resolve conflicts. And then students, of course, don't always see good behavior modeled. They sometimes see poor professional behavior modeled. And faculty took the opportunity to help students reflect on those experiences as well. In fact, faculty talked about modeling more than anything else, but reflection is what you'll find in the literature more than anything else when it comes to forming a professional identity. And the participants in this study did discuss reflection. It is in reflecting that we decide which values, attitudes, and behaviors to adopt and to integrate into who we are. So reflection needs to be a very deliberate part of our educator practice, and it can occur in individual written assignments, or it can occur in dialogue with all the students together or just between the faculty member and the student. And we can certainly work on developing our skills at writing good questions for reflection. Altogether, this model putting the pieces together looks very much like a concept that's found in the K through 12 or primary and secondary education literature. And that concept is called pedagogical caring. The concept of pedagogical caring is largely absent from the nursing education literature, but it bears further exploration. Pedagogical caring is the deliberate integration of a caring ethic into the teacher-student relationship. It requires investment in that relationship and knowing and adjusting to individual student needs, focusing on the needs of the student and engaging in dialogue with students. This is a value-added proposition if you think about it in nursing education, because it looks very much like holistic nursing practice when we're taking care of patients. So in other words, nursing educators teach caring by caring for and about students. Next slide, please. I hope you found this information helpful. Now, this study focused on pre-licensure baccalaureate nursing students in the US, which leaves many questions open with other student populations. Of particular importance, the participants in my study agreed that a whole lot of professional identity formation occurs in the first 2 to 3 years of practice after they graduate. So that's an area where we really need to do some deep research on what's effective in helping new graduate nurses form their professional identities. Another important area of research focuses on the transition from basic to advanced practice. My colleague, Dr. Rhoda Owens, will share the results of her research on nurse practitioner professional identity formation in rural primary care settings. Next slide, please.
Thank you, Kristen. I just thank for the opportunity to present my research. This is my most recent research study. I have done research on clinical instructors forming that new professional identity, and also on nurse practitioners. I was especially interested in nurse practitioners because I do work in a casual position since I started in academia at an urgent care clinic, and all the providers are nurse practitioners, and I was very fascinated at how they were able to take on this role of a provider from working as a registered nurse at the bedside, and just really interested in exploring that. Next slide, please. So the purpose of this study was to explore the perceptions and experiences of rural nurse practitioners while they transitioned from being registered nurses to family nurse practitioners. In addition, the study examined if and how new family nurse practitioners experienced their professional identity formations in their first year of rural primary care practice. Next slide, please. So IRB approval was obtained at all sites. The methodology was qualitative design. I used 3 Midwestern University nursing programs. I obtained email or contact information on graduates that supposedly were going to work in a rural healthcare setting. So I emailed 20 of the eligible graduates. 12 agreed to participate. So all participants were licensed family nurse practitioners who provided primary care at a rural healthcare facility located in one of 4 full practice states. They worked in 12 different healthcare facilities that were all clinics. And I conducted 2 individual participant semi-structured digitally recorded interviews per Zoom. One was at 6 months and one 12 months after beginning practice. Interviews were transcribed verbatim. Next slide, please. So the final demographics of my participants are as follows. Actually, 2 of the programs offered a DNP degree and 1 an MS degree as the terminal degree in which graduates were able to take the family nurse practitioner certification exam. So 7 had DNP degrees, 5 had MS degrees, 84% were female. Their ages ranged from 27 to 55 years. The mean was 33.8 years. 90% were white, Native American 10%. As far as working as an RN prior to beginning in the nurse practitioner program is anywhere from 5 to 29 years with a mean of 10.4 years. 11 actually lived in a rural community. 1 lived in an urban community. 7 lived in the same community as the healthcare facility. 5 commuted from 18 to 120 miles with a mean of 55 miles. Next slide, please. So 4 themes emerged from the results of all the data analysis. The first one was learning new knowledge, skills, roles, and responsibilities. They all realized that when compared to an RN, their nurse practitioner scope of practice required new knowledge, skills, roles, and responsibilities. This realization began during their education and clinical experiences in their nurse practitioner program. The experiential learning or hands-on learning in the clinical setting was especially important. All this built on their previous RN knowledge, skills, and experiences, all express similar ethics, values, and morals as nurse practitioners. However, now they realize that they are providers of care and many times leading that interprofessional team. Some examples of how their roles and skills are different as a nurse practitioner is diagnosing diseases, ordering laboratory and other diagnostic tests, prescribing medications, managing chronic diseases, evaluation of treatment plans. They all value the importance of lifelong learning and that learning will never stop. The second theme that emerged was interactions with patients, providers, and interprofessional team members. These interactions and relationships were very important. They provided further experiential learning experiences and further reinforced their nurse practitioner professional identities. All believe these individuals perceive them as nurse practitioners, and this helped them also perceive themselves as nurse practitioners. They value the importance of collaboration and teamwork. The relationships with their patients and families were also very important. They all felt respected, valued, and autonomous. Either having an assigned mentor or finding a mentor was very important during the past year. Third theme that emerged was incentive to learn and practice in rural healthcare. All had experience with working as a registered nurse in a rural healthcare setting, either a clinic or hospital prior to starting their nurse practitioner program. They were all very passionate about providing rural residents access to care. They also valued having autonomy, challenge, a variety of rural patients, learning unique skills to rural healthcare. Some of the other items that helped attract them to that clinic were an actual job opening and also student loan reimbursements. But they felt that that rural clinic had a more closer family-like working environment. As students, they had experienced both rural and urban facilities, and they preferred the rural healthy workplace environment. And lastly, the professional identity formation. For participants, this process began during their nursing education programs and continued throughout their first year of practice. To begin with, when they started school, their nursing education program, and as they entered practice, they were overwhelmed. But after a year of practice, they felt very confident and competent. So these themes led to the emerging model to further discuss and analyze the overall findings. Next slide, please. The emerging model, the process of professional identity formation for rural family nurse practitioners. Next slide, please. As you can see in the model on the left, as you look at us on your left, they came into their nursing program with their registered nurse professional identity. They began the process as experienced RNs that made the decision to pursue a new family nurse practitioner career. They all believe that they were expert registered nurses who demonstrate competence and competence. So the process of transitioning from their registered nurse professional identity to their nurse practitioner professional identity occurred through all of this interaction of all these parts. Learning new knowledge, skills, roles, and responsibilities was central to that participant's successful transition and nurse practitioner professional identity formation. It built on their previous clinical experiences, knowledge, and skills, which you can see in the left lower corner, and also throughout their nurse practitioner education programs. They had an incentive to learn, which you can see above the learning new knowledge, skills, roles, and responsibilities. That was very important. They felt they just wouldn't be able to be a nurse practitioner without that learning. And they also felt that even once they became a nurse practitioner, and actually throughout this year, they would need ongoing professional development. And they were very motivated to do that because they wanted to be able to give safe quality care. The interactions with the patients, families, providers, and interprofessional team members, which is below the learning new knowledge, skills, roles, and responsibilities, that was also very important to provide those learning experiences that helped their perception of themselves, and also they felt they were perceived. They valued all these relationships, especially with their patients and families. And all this together, you know, all the relationships with the team members and other providers were very civil, respectful, autonomous. And so that fed into that professional comportment definition that we've talked about earlier. And so by able to successfully obtain that nurse practitioner professional identity, they had work satisfaction. And so this really drove that. And all of this whole process occurred in the rural communities and healthcare facility environments. And overall, they have this passion and incentive to provide healthcare access and quality care to rural residents. And that just came through many times, all of them mentioned that throughout their interviews. All of them, except for the one, lived in a rural community. That one person that lived in an urban was in the process of moving to a rural community. Those that lived in another rural community from their clinic were there because basically their family lived there. Maybe they were married to a spouse or they had a significant other, and so they weren't able to relocate. Next slide, please. So this research findings have implications for nursing education programs and healthcare facilities. First of all, if you know anything about rural nursing theory, this really adds to that because there's been very little research with rural nurse practitioners. And so there is more that needs to be done there. Professional identity and nursing formation must be taught in all levels of nursing education programs. We heard that in Kristen's presentation and what some of Joe has said. And because it is different from LPN to RN to advanced practice registered nurse to all the different specialties even of advanced practice nurses. This model could be used as a framework to guide leaders at nurse practitioner programs as they review curriculum. Also, the model could help guide healthcare facility professional development programs for nurse practitioners to help provide that needed support to foster that nurse practitioner professional identity formation. Also, there needs to be collaboration between nurse practitioner education programs and the clinical healthcare facility sites. We know how important it is for that education piece while they're in school, you know, both at the undergrad and then the grad level, to be able to help foster that and know what professional identity nursing is, and be knowledgeable as a preceptor and so forth. Also, policymakers must continue efforts to increase the number of states allowing nurse practitioners full independent practice. All of these were in, you know, full practice states, and of course provided much work satisfaction. And lastly, further research is needed. Next slide, please. So you will, I know you'll have access to these slides in the next week or so, and here is the reference to the published study. So if you want to read more about it, I encourage you to do that and email if you have any additional questions. So next I'll turn it over to Joe to finish the rest of our presentation.
Next slide, please. Thank you, Rhoda. Weren't those research studies excellent? I enjoyed listening to them again, and I've heard them once already. We're going to end up a little bit by looking at the big picture. We've looked at education, we've looked a little at the profession, and we've gone through some related research as it pertains to professional identity. But what we do know is that the overlapping complex regulatory and oversight scheme also serves as a barrier to professional identity development. Rhoda alluded to that when she said some states have full practice authority and others don't. Different identities possibly in those states. We have a lot of nursing organizations out there, 80 at the national level and more than that at the state and local level, and all exist to provide guidance to nurses. Some also include some fairly significant pieces of developing our profession and our identity within our profession. The National Council of State Boards of Nursing, which oversees the licensure exam, American Nurses Association, which has developed standards of nursing, and the Code of Ethics for Nurses, and STTI, which is putting on this series of webinar right now to try and increase excellence in nursing. Those are a number of different organizations that all make decisions and guidance for how nurses view themselves and how they act, feel, and behave as nurses. State legislatures in every state enact the Nurse Practice Act for the state, sometimes with collaboration with the State Board of Nursing, sometimes without. The state boards of nursing then serve to effectuate that Nurse Practice Act through licensure, discipline, and regulations related to the Nurse Practice Act. Each state is very unique. Some have peer assistance, some don't. Some require continuing education, some don't. Some have education and academic oversight, and some don't. You can see how disorganized that could be. Next slide, please. Then there are the civil and criminal codes. You might be thinking, what do they have to do with professional identity? The fact of the matter is that there is an enormous web of federal and state laws and regulations that bear on healthcare. In the first several years of the Obamacare Act, there were over 30,000 new regulations for healthcare providers, all of which serve to define what we can and can't do, how we should do what we do, and impact how we see ourselves as nurses. As a plaintiff's medical malpractice attorney and as a defense attorney doing disciplinary defense, I learned pretty quickly that a nurse's reputation and career can be destroyed via legal proceedings when laws are violated or regulations are breached. Also, some of the civil courts utilize nursing standards in their rulings and judgments. Then there are certification bodies, which develop the parameters of specialties and also serve to authenticate specialized knowledge through their certification exams. Those connect with states in that most states require certifications, but not all states do. And finally, I touched on the Nurse Compact, which exists between 29 states right now and extends the ability of the nurse to practice in all 29 of those states. However, the compact doesn't change how the Nurse Practice Act in each state reads. And so each nurse extending into each state must understand and comply with the Nurse Practice Act, which defines nursing in that state. Finally, the workplace. Individual healthcare settings and organizations operate on protocol-driven care, which sets the internal standard of care for the nurse and seeks to define what and who nursing is within the institution. Next slide, please. Then there are external factors such as negative or inappropriate stereotypes in the media, which interfere with our ability to see ourselves as professional nurses. The social media use by nurses. Many nurses believe that what they do personally is very different from what they do professionally, but both DeCamp and Westrick have done quite a bit of work showing that what you do in your private social media can have negative impacts on your professional life, and we certainly found that to be true at the Board of Nursing. Overlap in practice arenas between medicine and nursing complicates the picture. Then there's international development, where we're extending our excellence in nursing efforts across the globe to nations that may be more developed or less developed than what we think, and who have different cultural practices that must be factored in. Next slide, please. So you can see it's a very complicated picture, and a lot of research is needed to give us clarity on who we are at all nursing levels. Professional identity education must encompass all four of those domains and be holistic. The pedagogy needs to be cohesive and well integrated, and we must intentionally foster professional identity with caring students, with nursing students. Kristen talked about caring pedagogy. That's how we integrate all this. We enhance continuum between hospital-based preceptors and nursing program faculty. We must integrate the perspectives of education, practice, and regulation and oversight to be cohesive and uniform so that we can produce nurses who enter practice fully equipped to practice effectively and safely. Next slide, please. We finish this then with the vision. Every school of nursing will adopt the professional identity model to be taught as a distinct component of nursing, and every school of nursing will focus on developing the adopted professional identity model components in nursing students at all levels. Thank you much for your attention. Next slide, please. If you want more information, it can be found at the website on this slide, at the Society for Professional Identity in Nursing home base. Next slide, please. And if you'd like to join our work, you can contact Lauren Roberts at the email address on this slide. Again, thank you so much for your attention. We may have just a couple minutes left for questions, and we'd be happy to entertain those.
Okay, here's the first question. Is egoism more of a Western way trend? In other words, is this truly globally? Let's see. Is that Joe? Would you like to take that one? Did you talk
I'll
about
take that one on.
Yeah, okay.
I do believe that egoism tends to emerge out of the Western cultures and is predominant in the Western cultures. Having grown up and lived in another culture for many, many years, there certainly was not the level of egoism there that I see here. However, with social media, the internet, the availability of so much information, I think we can safely say that concepts of egoism are spreading rapidly around the world.
Okay, here is the next question. I have found that nursing faculty are not always collegial and politics can dominate to the point where I return to clinical practice. How can nurse faculty be more cohesive?
I'll start with that.
Okay.
I think faculty are a subset of the society, which right now is not very cohesive either. But I will say, I think having a uniform definition and model of professional identity would go a long ways. You know, early on, I said students see professional identity very differently, and so do faculty. And I think it would go a long ways if we had that uniform definition.
Yeah, that's a good point, because I believe that, you know, you have professional identity in any part of, just depending on whatever practice in nursing. And we still have to practice or take on those 4 domains, you know, no matter where you're at. And so just to make sure that nurses in whatever area they're practicing are knowledgeable about that and actually, you know, just uphold that definition. Do you have anything to add, Kristen, on that one?
No.
Okay. All right.
I think there's a question for you in the Q&A, though.
Is there? Oh, okay. What guidance can you offer regarding the pandemic and moving on to begin as a MSN prepared RN with interest to continue to APRN and family nurse practitioner? See how to go about that one there. It's, you know, it's a challenge. It's a challenge to go to school, definitely. I have nurse practitioner students right now in a class that I teach on ethics, legal, and health policy, and it's tough. You know, you have to be, I guess, faculty, you know, if you're teaching those students too, you need to be very understanding. You need to role model that understanding behavior and that flexibility, and, you know, through email or phone call conversations or Zoom, just to be very understanding. But if I ever hear of any nurses that want to become an advanced practice nurse, I say, go for it. because I think there's going to be more and more demand for family nurse practitioners. I really do. And if anybody's interested, you should pursue those goals. Anybody else want to add anything to that?
Rhoda, I would second that. I would say now more than ever, go for it. It's not easy. There are complications to your education, including finding preceptors in the clinical settings, but go for it. This is not the first difficult situation we've ever encountered, and it certainly won't be the last. So I would say, don't be discouraged, jump in.
Yeah. And even once you get going in that nursing program, you know, and if this continues on for a while, just keep your faculty in the loop and try and be understanding of your preceptors too. It's stressful being a preceptor to a nursing student, whether it's an RN student, an LPN student, or a nurse practitioner student now with everything going on. So let's see, do we have time for any more questions, Matt? Okay, there's another question here. I am very interested in the vulnerable population of students. I have a strong passion for trauma-informed care and have recently begun to learn about trauma-informed classrooms. How can trauma-informed care be used appropriately to assist students with professional identity formation? Would that be you, Kristen?
Yeah,
Yeah.
and Samantha, these are great questions, you know, because there's a careful balance there. You know, if you recollect that Joe put up a slide with a little schematic from the U.S. National Council of State Boards of Nursing on professional boundaries between nurses and patients, but there's a zone of helpfulness. There's a too distant, it's not helpful, and there's too close, and that also can be damaging. So it is important to set boundaries with students, but it's also important to understand them. And so, you know, I've often had to think about, okay, my role here is the faculty member. I'm not the student's nurse. So what I can do is talk to them and explore and figure out that they have a need, and then refer them to the other resources that are available on campus that can more appropriately meet those needs. But part of forming professional identity is also addressing inappropriate behaviors and setting those boundaries, and that helps those students grow. And it's not a lot of fun as the faculty member. I can tell you one of the things that I've done dozens of times is have the plagiarism conversation. And I have a box of Kleenex on my desk because any kind of confrontation is very emotional for the students. But understanding that this helps them in their development, and reflecting on the times in my own life that the only thing that made me change was hitting a boundary really hard that wasn't going to move, that really helped. But definitely over the years I've had students who've had all kinds of trauma, and it's important that I set those healthy boundaries, but that I understand that that's where they're coming from, and thinking in terms of a growth mindset, like who they are today isn't who they're always going to be. My job is to help mold and guide and direct them along the path to who they're becoming. So they're on a journey, I'm on a journey. That's kind of how I think about that. And there's a question up above about Christine Tanner's work. Yes, everything Christine Tanner does is very, very useful.
Yeah, that was going to be my next one. Good.
Yeah.
Thank you for addressing that, Kristen. Okay, here's another one. Professional identity for APRNs in Jamaica is very fragile as we experience continued pushback from medical doctors who are threatened by the autonomy. Any suggestions on how to overcome this hurdle without causing further professional conflict? That's an interesting question, because I think in the United States too, several years ago, it used to be much more difficult for our APRNs to practice, but I believe it's getting better. Of course, it depends on, what your practice. So I suppose, in Jamaica, it depends on what your scope of practice is too. And I guess, talk to, your managers, your directors, I guess, see if you can have some conversations with the medical doctors and sit down and have a conversation, or get on committees together and just kind of work on establishing that collaborative teamwork. And of course, it's different in every culture and country, I'm sure. but just baby steps, I think, because I think, APRNs in the United States felt that 2 years ago. So anybody
Well-
else want to add anything to that?
Well, yeah, I mean, I agree. This is one of the reasons we really want to
Mhm.
partner and do international
Mhm.
research on professional identity development, because different countries are at different places in the arc of the development of the profession, of the discipline of nursing. In my heart mostly is in Africa, and the places that I've been in Africa, nursing's at a very different place than it is in the United States. But there's a lot we can do to help each other, and it's wonderful to learn about different cultural
Mhm.
contexts and where nursing is. And so one of the things I keep telling my students and my 14-year-old who's studying world geography and history is like, how do you use this? I actually use this a lot. My understanding of the history of nursing helps me place what's going on, just like you referred to, Rhoda, that APRNs may be a newer thing in Jamaica than they are in the
Mhm.
US, but I can see the arc of that development compared to how that role has developed in the US. And
Mhm.
I live in Texas. APRN's professional identity is more fragile here than it is in rural Minnesota, too. There are a lot of variations in the United States.
There definitely are. So, yeah.
I would say additionally, it is a multi-pronged
Mhm.
development. We develop by partnering and informing. I know at the board in Kansas, when we sat down with the medical board, they had no idea really what nurse practitioners even did. And it took some time for us to even enlighten them as to what we did. And once we did that, we were more collegial and could support each other a little more. But even in the US, only 28 states have full practice authority.
Mhm.
So
Yeah.
there's a long ways to go for us too. And certainly we have uniform issues that we can address legislatively and collegially and with our nurse leadership.
Mhm. Okay, we do have another question here. I am concerned about how the decreased clinical experiences will impact undergraduate identity formation in the steps from Kristen's putting it together slide. Is there anything we as educators can do to mitigate this impact? So Kristen, you want to take that one?
Yes, and I believe Matt has signaled us that this will be the last
Okay, the last
question.
question. Okay.
Well, of course, was it the National League for Nursing that did the big study several years ago about really how much simulation versus clinical experience we can do and still have the same kind of outcomes, and the sweet spot's about 50-50. And I'm still teaching in the clinical arena, and so I was in last March. I had junior one first semester in the hospital students, and we did a hard pivot from we're going to clinical every week to we can't go to the hospital at all for the rest of the semester. And understanding this, putting the pieces together was really helpful to me in framing what I needed to do with my students and helping them to reflect on their own learning. Because, nursing students are very intense. They were afraid that missing this 6 days in clinical was going to keep them from being nurses. So no, we're going to focus, even though we can't put our hands on patients, we're going to focus on thinking like a nurse. And they really developed their critical thinking skills while we did some very focused unfolding case studies that they had to present themselves and ask their colleagues questions. So their time in the hospital really gave them a sense of the holistic nature of nursing. But then when we weren't able to put our hands on patients, we still were able to use reflection and use really important thinking exercises to learn to think and feel like a nurse.
Thank you so much to our panelists, our presenters today, for all of this great information. Sigma is grateful that you took the time to share with our audience, and we look forward to hearing more from you in the future. As a reminder to our attendees, please submit your state or country you're from in the questions feature. We hope you've enjoyed this webinar. Be sure to check out Sigma's upcoming webinars, podcasts, and resources to support you and your colleagues at www.sigmanursing.org. Also, previously recorded webinars and podcasts are freely available on the Sigma repository. Thank you for joining us and have a wonderful day.
Thank you, everyone, and thank you for all your wonderful comments.
Yes, thank you, everyone.
Thank you for the questions as well.
Mhm.